Hi, Mike Gibson, Cindy Grines coming to you live from SCAI 2015. Cindy, the SCAI and 38 other groups have introduced a bill to our United States House of Representatives called the Research for All Act, and it specifies that there should be inclusion in separate analyses of male and female animals, tissue, and cells in research conducted and funded by the NIH. So it's good to see that at least our government and others are recognizing the fact that we often haven't been as inclusive of women in clinical trials. So only about a quarter of people in trials are women. So good to see this. So why haven't we had more women in clinical trials?
Well, I think it's a problem for a number of reasons. One is with cardiovascular disease, even though it's the #1 cause of death in women, by the way, it greatly exceeds the next 4 causes of death, including cancer.
Right.
But despite this high prevalence of cardiovascular disease, it often strikes women at a late age, and they have other comorbidities, or they may be too frail to participate in the research, because prospective research requires them to meet the inclusion criteria, correct? And in addition, women have a tendency to refuse participation. In part, that might be because they're more fearful, but also they have these tendencies to want to take care of everybody else. So they're worried about the husband, they're worried about children at home. They don't have time to come back for follow-up visits.
Right, it's kind of sad, you know, I mean, they're very selfless and they care about everyone else rather than themselves. And so we don't really have adequate representation. So even though we are analyzing some of the information by men versus women in many of our studies, we just don't have enough women to have adequate numbers to really get a definitive answer, sadly, right?
Correct. So we're trying to do more research involving just women in general.
Right. How do women differ from men? Are women just smaller men?
Well, absolutely not. I mean, some men might like to think that, but there are huge differences. Take acute MI, for example.
Right.
I mean, let's start out with just the presenting symptoms. A man will have crushing, pressure type of chest discomfort, whereas women will have very atypical symptoms. They'll have fleeting, sharp, stabbing pains. It might not even be in the chest. It could be in the neck or in the back. Or they could just be short of breath. What happens is that women do not recognize those symptoms, and so therefore they present to the hospital much later. And once they get to the hospital, the medical team doesn't recognize the symptoms, and then they tend to be treated later, if treated at all. So it's created a huge problem.
And less often undergo invasive testing.
Exactly.
You know, I think similar to not wanting to participate in the trials because they're really worried about everybody else, there's a lot of denial sometimes there with the symptoms, and they don't want to bother anybody, or I need to find someone to look after my cat, or, you know, there's a lot of issues that keep them from coming in a timely fashion.
Exactly, and some of it might even be embarrassment. So for example, there was a survey that asked women, if you had somebody, a loved one that had symptoms of, you know, they gave some symptoms of heart attack, would you call 911? And about 79% of them said yes. Then they asked the question, if you yourself were having these symptoms, would you call 911? It was less than 50%.
Really?
Yes.
And was it different between men and women, do you know, or just
I
don't know the gender difference? But sadly, you know, there's a lot of denial. A lot of denial there. What about response to therapies? What about response to antihypertensives and other treatments? Are women as responsive as men?
You know, that's a good question. I'm not quite sure about antihypertensives. I can tell you with regard to antiplatelets, yes,
and
antithrombins, yes. If anything, they have more bleeding complications than men. Some of that might be due to differences in dosing. So, for example, women tend to be smaller, and perhaps we're overdosing them. Another issue with drug pharmacology.
And they're older,
They're older, their vessels might be more frail, they might have other comorbidities that lead to more bleeding. They could have more renal dysfunction, which causes accumulation of the drug in the bloodstream. Or they tend to have less muscle, more fat, so it affects the metabolism and storage of the drug.
Exactly.
So there's a number of reasons why they might have totally different pharmacokinetics compared to a man.
So they're clearly not just smaller men. I mean, there are a lot of different underlying pathophysiologic differences between the two genders or sexes.
Absolutely. In fact, if you go back to heart attacks, right? Heart
Yeah.
attacks are mostly caused by atherosclerotic plaque rupture causing occlusion of coronary artery. Well, in men, it's a plaque rupture. With women, you might have a little more plaque erosion,
Exactly.
where it's occurring in a vessel that may not have a large lipid pool.
Yeah.
In addition, women are much more prone to have an acute MI due to spasm, coronary dissection, which happens almost exclusively in women,
yes.
spontaneous coronary dissection, and then Takasubos,
Right,
the
yeah.
catecholamine-mediated MIs are 8 times more common to occur in women
Right.
compared to men.
Right.
And so there's huge differences in the mechanism of MI. And then the other thing that's very interesting is that, women have a higher mortality with MI.
Sure.
Now in the past we've blamed it on a couple things. Number one, they're older. Number two, they have more comorbidities. Number three, they're not receiving timely,
Right.
effective treatments, right? But interestingly enough, a couple of studies have now looked at age differences. And if you look at elderly women compared to elderly men, they have similar mortalities. And the big difference is in the younger women.
Really interesting.
Yeah, so the younger women have a much higher mortality from the MI compared to a younger man.
Interesting. Why is that, do you think?
Nobody knows. It could be that, we have, again, this different mechanism of MI in a younger woman could be contributing to lack of development of collaterals, and maybe they're more likely to die because of that. And of course, women have smaller ventricles, they have smaller stroke volume. So if you lose
Right.
part of that ventricle, you're more likely to go into cardiogenic shock.
I see. Interesting.
And then I think as physicians, we miss MI in young women because, they could have an MI without any risk factors at all. And then we don't even think MI when they come in with their back pain.
Yeah. Well, they have, obviously, when they're young, you're conferred some protection due to the hormonal differences, but if you're having an MI despite that, maybe there's some other unrecognized risk factor that's playing a role there that we don't understand.
Well, that's true, and so we have these unusual mechanisms, but again, the normal cause of an MI are risk factors. And the Virgo study, which was a study done just exclusively in younger women, I think it was women under the age of 55, they did find that the majority of the women did have at least one risk factor. So the risk factors affect women differently, though. So, for example, if you have diabetes, if I have diabetes, I'm much more likely to have an MI compared to you if you have diabetes. If I'm a smoker, I'm much more likely to have an MI compared to you. And not only that, I'm much more likely to develop peripheral arterial disease than you, if you're a smoker. If I have high triglycerides, it's the same story. High triglycerides are a huge risk factor in women, but not in men.
Interesting.
So there's big differences between men and women with regard to the risk factors also.
Interesting, yeah.
And not only that, those are the traditional risk factors, but women have non-traditional. So for example, if I'm pregnant and I have preeclampsia, gestational diabetes, that confers a risk way out, decades later.
Right, interesting. I didn't know. So even long beyond the pregnancy, you're still at risk.
Absolutely, that's a risk.
Interesting.
And maybe it's a
that.
marker for some underlying vascular pathology.
Yeah.
We don't know. But other things like elevated CRP in women is a higher risk factor. So it's just very unusual, the risk factors in women.
A lot more autoimmune processes in women because of when you're pregnant, some of the fetus's stem cells actually cross the placenta and get embedded in a woman. So you have this microchimerism where you have these little remnants of the fetus, and it can be a male inside your body. When you look at a lupus area on a woman, it actually has stains blue for the male, so you have a lot more autoimmune disease in women as well. So maybe some of that plays a role.
Right, and autoimmunity, of course, confers a higher cardiovascular risk.
Right. Cindy, let's talk a little bit about women in cardiology and leadership in cardiology. Very proud of you. You're assuming a big leadership role now. I think, that's great to see that women taking a leadership role in cardiology. How's everything going for you in this kind of new leadership position?
Oh, great. Well, so the position is the WIN, which stands for Women in Innovation, and I'm the current chairperson of the SCAI committee on that. And we have a three-pronged goal. We want to professional development of women in the field of cardiology. We want to do research and education. And so the fostering, we just had a big session that was very well attended, standing room only, as a matter of fact, where we put on, it was called Complex Cases Coast to Coast. And we had featured a lot of female faculty on the panel, as well as female fellows who presented.
That's great.
And so that was really great.
That's
with
great.
regard to the research we're doing, we did a research study on looking at women. In women, interventionalists are only about 4.5% of all interventionalists in the country.
Right.
And we tend to be low volume. We're only doing about 2.8% of all angioplasty cases. And so, you know, learning that, we're trying to foster more women to go into cardiology and then interventional. We're going to try to do some practice development counseling
that's good to
as well.
see. That's good to see. What do you think women have shied away from interventional cardiology?
Well, it's, you know what it's like. I mean, it's long hours, it's grueling work, and it's a surgical field. In general, you have to be very tough and determined to get ahead. It's a shark tank, so you have to be able to swim with the sharks. That's the analogy I use all the time. But at the same time, you can't be a shark yourself. Right. The expectations for a woman is that you are sweet, and you're kind, and you're nurturing. Yeah. And so it's hard to juggle because you know I'm one of the few people who have been successful, along with Roxanne and other people. But it's a tight.
You're both very sweet.
Well, it's hard. It's hard to know the right thing to do or the right thing to say because you have to be firm, you have to be tough and assertive, but at the same time you have to still be sweet in a little way.
I understand. Well, congratulations on leading all those efforts.
Thank you.
Thanks for joining us here today, Cindy. And thanks to all of you for joining us here live from SCAI 2015.